The name of this program is An Introduction to Opioid Use Disorders. This activity was developed by Achieve CE and is free of any commercial support. I have no financial interests or relationships to disclose. My name's Dr. Patricia Dunn. I'm an advanced practice registered nurse with a doctorate in nursing practice. I'm a board certified family nurse practitioner, and I have clinical practice background in internal medicine, cardiothoracic surgery, electrophysiology, gerontology, and most recently, pain management. The purpose of this course is to provide nurses with a greater understanding of the current crisis related to opioid abuse in the United States, along with to provide information necessary to recognize and act appropriately in the presence of an opioid-related event. The course objectives are: number one, discuss the increasing prevalence of opioids in drug abuse and drug-related deaths in the United States. Number two, distinguish the difference between opiates and opioids. Number three, name examples of natural and synthetic opioids. Number four, identify the primary factor contributing to the rise of opioid abuse in the United States. Number five, define opioid abuse and/or dependence as outlined in the DSM-5. Number six, identify signs of opioid abuse. Number seven, identify signs of opioid overdose. Number eight, define and identify likely signs and symptoms of opioid withdrawal. Number nine, name the 3 symptoms found in the opioid overdose triad. And number 10, discuss the initial treatment of an opioid overdose. So if you turn on the radio and you listen to NPR, or you watch CNN, or you read the Huffington Post, or you Google the Centers for Disease Control and Prevention and read some of their press releases, it seems like everybody's talking about the opioid epidemic facing the United States, and there's plenty of good reason for that. According to the CDC, in 2016, more than 11.5 million Americans aged 12 and older reported misusing prescription opioids. But this is not a new problem by any stretch of the imagination. Some of the first studies on opiate abuse and addiction were done as far back as 1875 by Dr. Edward Levenstein. And he wrote a paper entitled Morbid Craving for Morphia, a monograph founded on personal observations. And in his paper, he wrote about people who were taking morphine and would start to have cravings between doses and would start escalating their doses. Opium was also used by ancient Greeks, Romans, and Egyptians, and there's writings that have been found warning of overdose from opium or using it in suicide, which was actually legal in ancient Rome. In the 1800s, there were opium wars, and the first opium war was fought in 1839 between China and Great Britain. So during this program, you may be thinking about maybe family, friends, neighbors, patients, coworkers who you might have encountered that have been touched by this problem or have this problem. And I'm sure most all of us can think of at least one person. So this is a map just to get a general idea of how the states stack up comparing to the national average. And it's a CDC map of the 2017 age-adjusted drug overdose death rate by state. At that time, the US average was 21.7 deaths per 100,000 people. And that number is represented in light blue, and you can see those states. The dark blue states actually had a higher death rate, and the lime green states had a lower death rate. And you can see the concentration with the higher rates were kind of in the east, northeast, and the states that were kind of average, you can see in the lower states as well. So a CDC report back in 2016 stated that drug overdose deaths nearly tripled in the 25 years between 1999 and 2014. And of the over 47,000 deaths, nearly 61% involved an opioid. In 2018, there were more than 67,000 deaths from opioid overdose, which was actually a 4% decline from the prior year. However, there was a 10% increase in deaths from synthetic opioids. So in 2017, close to 60% of the opioid-related deaths involved fentanyl, compared to 14% in 2010. And that's a dramatic increase in just 7 years. So the news is not particularly good, and it's not gotten any better, because since the pandemic, the recent updates from the CDC show that more than 87,000 Americans have died from drug overdoses between October of 2019 and September of 2020. This represents a 29% increase in overdose deaths compared to the prior year, and the highest opioid death rate from any year since the opioid epidemic was recognized in the 1990s. This is a graphic depiction of drug deaths in the 2 decades between 1999 and 2019. The red line shows synthetic opioids, primarily fentanyl, which you can see took a sharp increase around 2013 and has really spiked in the last few years. The medium blue line shows prescription opioids and methadone, which has actually had a little bit of a downward trend since 2017, and we'll talk about what's happened since 2017 a little later. And the gray line is heroin, which had a dramatic increase around 2011 in death rate, but has also had a little bit of a leveling off or even a slight decline since 2017. This slide shows a comparison of drug overdose deaths between males on the top in the yellow line and females in the reddish brown bottom line, again, between 1999 and 2019. So the men are outpacing the women, and the men have seemed to have a rise in between 2015 and 2019. The women have kind of stayed stable for some reason. So if you stratify the CDC statistics, reports show that most opioid-involved deaths featured the use of heroin or another synthetic, not including methadone, which seemed to be declining a little bit. But primarily, one of the main suspects among the synthetics is illegally produced fentanyl. And if you Google the most commonly abused drug, fentanyl will be one of those at the top of the list. And illegally produced fentanyl or synthetic fentanyl is 50 to 100 times stronger than morphine. It's developed as a powder and can be used in multiple ways. It can be liquefied and dropped on blotter paper, put in eye drops, put in nasal spray. It can be kept powdered and smoked. It can be injected or made into pills that look like other prescription medications. It goes by multiple street names, including Apache, China Girl, Chinatown, China White, Dance Fever, Goodfellas, Great Bear, He-Man, Poison, Tango, Cash. I mean, if you hear patients or people talking about things like this, that's what they're talking about. They're talking about fentanyl. Pharmaceutical fentanyl is also available, and it's a prescription commonly used during surgery or for post-op pain management. And it's also used for chronic pain relief in patients who have a tolerance to pain medication or with cancer-related pain. It's marketed under the name of Sublamace, Actique, or Duragesic, and it comes in injection, patch, lozenges, or cough drop. And it's also a drug of abuse, but a little harder to get than the illegally produced fentanyl. Why is fentanyl so dangerous? Well, maybe this picture will help a little. This is a visual depiction of lethal doses of a couple of these opiates. The dime is just for size comparison. So you see, first is heroin, and this is 10 to 12 milligrams for the average person would be a lethal dose. You can see next to it is fentanyl, and 1 to 2 milligrams is considered a lethal dose. And next to that is carfentanil, which 0.02 milligrams is a lethal dose. And you can see it's only a few grains really. And the problem is when people are taking drugs, street drugs, they have no idea what they're taking. They buy a white powder. It could be crushed up Tylenol and aspirin. It could be heroin. It could be fentanyl. They don't know. They just ingest it, and pretty soon they're in an overdose situation. The financial impact of the opioid epidemic is staggering to a country. In 2017, the estimated economic burden to the United States topped $1 trillion. That includes costs associated with opioid use disorder treatment, rehabilitation, healthcare costs, loss of productivity, criminal justice system expenditures, and of course, the costs associated with death. According to data from the US Department of Justice, approximately half of state and federal prisoners meet criteria for substance use disorder. But opioid use disorder goes largely untreated during periods of incarceration, and drug use is common during incarceration. But if opioid use is interrupted during incarceration, it will often resume after release. And if opioid use resumes after a period of abstinence, overdose is highly likely because many people will resume their use at the same level that they stopped at. And the system is naive to the drug, and they will promptly overdose. The US Department of Health and Human Services in 2014 said that at least half of the opioid deaths involve prescription opioids. There's been efforts to curb this. So in 2019, they're saying 28% of opioid overdoses were related to prescriptions. So with the proliferation of opioid abuse and prescription abuse, it's likely that most nurses are going to encounter some form of opioid-related event, either intoxication, opioid withdrawal syndrome, diversion of medications, or something similar sooner rather than later in their career. And we're hoping this introduction, this program, will help you to know how to handle that if it occurs. So things to think about. Have you encountered a patient or a person you think might be misusing their medication? They might not look like you expect them to look, and they might be in a setting where you think you have control. Back in the 80s, before there was any talk of an opioid epidemic, I was working on an orthopedic unit, and I had a 35-year-old security guard come in for lumbar disc syndrome. And back then we did Bucks traction, and they would get Demerol and Phenergan every 3 to 4 hours as needed for pain. And this attractive looking, clean cut lady was on the button every 4 hours, wanting her Demerol, and we tried to give her the lower dose because she was getting a lot of medication. I went in to assess her between injections. She was wanting her next injection, and I found her, lethargic, slurring her words. Her color didn't look good. She was breathing about 8 times a minute. Of course, I opened her airway, ended up calling a code. She got Narcan and was sent to the ICU. And when we were packing up her things, we found that she had brought a bottle of Demerol pills from home and was taking those in between her shots. So she was abusing her medication. She didn't look like a drug addict or a drug abuser. And of course, I thought I had control of the situation because she was in the hospital. And those things can still happen. So it's something we have to keep an eye on. So opiates versus opioids. What's in the term? The term opiate and opioids are both seen frequently and often used interchangeably. However, they're not strictly the same. It used to be that opioids were synthetic opiates only, and opiates were those drugs that were derived naturally from opium or the poppy plant. However, now the term opioid is used to refer to all opiates, natural and synthetic. So opioids is the name given to drugs of all opiate class. So opiates are naturally occurring and produced from the poppy plant and include morphine, codeine, and thebaine. Heroin is often lumped into the opiate and naturally occurring class, but it's actually not a naturally occurring opiate. Morphine-based alkaloids appear in large concentration in the opium poppy, whereas heroin is actually derived from morphine and not found in the poppy, so it's actually a semi-synthetic. So for the purist among us, we actually have three categories. There's natural opiates, which are morphine, codeine, and thebaine. There's semi-synthetic opioids, which are oxycodone, hydrocodone, hydromorphone, buprenorphine, which is derived from thebaine, and heroin, which is derived from morphine. And then there's the synthetic opioids, which are methadone, which is often classified by itself, which is also meperidine, which is Demerol, and that's not commonly used anymore for several reasons, one of which being side effects like hallucination and confusion. And Demerol is frequently a drug of abuse because there's more high than help from it, we'll say. It's not as good for pain, but it gives people a real buzz, so to speak. Tramadol is also a synthetic opioid, and so is fentanyl. But whatever you want to call them, they act essentially the same way in the body, and they bind to opioid receptors. The receptors are called the mu, delta, and kappa receptors, and they're located throughout the body. They're found in the periphery, the dorsal root ganglia of the spinal nerves, the spinal cord, and the supraspinal region and brain. So opioids bind to all these sites, and that's how they work to affect pain, mood, and emotion. And that's what makes them so appealing and promotes them to be drugs of abuse. This is a nice little chart of opioid equivalencies, and it's just to give a comparison of opiate strengths. The gold standard is to measure on morphine milligram equivalents, and according to the CDC, patients taking opioid doses at or above 50 morphine milligram equivalents per day are twice as likely to overdose as those taking dosages of 20 MMEs per day, and the risk further increases as the MMEs per day increases. So you can see that 10 milligrams of morphine is equivalent to 100 milligrams of codeine, or you have to take 100 milligrams of tramadol to equal 10 milligrams of morphine, but you only need 5 milligrams of oxycodone or 2 milligrams of hydromorphone. Methadone's in its own special calculation because it's a long-acting drug and you have to calculate it differently. But look at fentanyl, it's measured in micrograms. So it's not even quite the same. Again, it can be long-acting. It can have a 3-day half-life or a 3-hour half-life, depending on the form. So again, the problem is people don't really understand this. If you have a patient in your clinic, you give them a 2 milligram hydromorphone and somebody else gets 100 milligram tramadol, they think they're being cheated because, oh, my friend got 100 milligrams, you're only giving me 2 milligrams. They have no idea that what they're getting, it's kind of like apples and bananas or fruits, but they're not really equal. So it's another reason why people can easily overdose and misuse their medication because they just really don't understand what's going on. Another problem is some of these medications are special, like methadone will not give people the high like some of the other medications, and it'll affect the brainstem and the respirations before it'll give them the buzz that maybe some of the other opioids will, like oxycodone. They'll keep taking the medicine, trying to get that feeling that they like, and their respiratory depression will occur. Or it can also affect the electrical rhythm of the heart. If they have electrical rhythm disturbance and don't know it, they can have cardiac arrest because of that. So there's a lot of reasons why abusing the medications can lead to death, not just from the obvious taking too much. So what are some of the contributing factors to the current epidemic? Well, when we're looking at it, we have to examine what's been happening in history. It's noted that the liberalization of laws governing the prescribing of opioids for the treatment of chronic non-cancer pain by state medical boards led to a dramatic increase in opioid use. And this happened back in the 1990s. And we now know that overdoses from prescription opioids have been driving overdoses for the last 15 to 20 years. So in the 1990s, pain was considered the fifth vital sign. Pain scales were all the rage. Pain of any sort was almost unacceptable. If you were in the hospital, Joint Commission of Hospitals had a standard related to pain. Patients' questionnaires were geared toward, was your pain adequately managed? Quality improvement efforts were aimed at pain management. Doctors' health scores depended on adequate pain treatment. So laws for prescription pain medication were liberalized. Around 1999, according to the CDC, prescription opioid deaths began to climb, and around 2015, it was more apparent that there was a big problem. So clinicians tended to overprescribe, and why do you think that's happened? Well, one thing we found is that a lack of training in pain management. A 2011 study in the Journal of Pain found that United States medical schools allot a median of 9 teaching hours on pain and its management. And that includes physiology of pain and the treatment of pain. And much of that revolved around pharmacotherapy. Little time to consider alternatives. A doctor might get 5 to 10 minutes with each patient, and in that time they have to figure out what's going on, order tests, order procedures, and figure out how to treat the person's discomfort. There's patient pressure. If you have a patient leave your office with an order to take Tylenol and exercise, they're not going to be very happy. And I've been in the position where patients really pressure you for pain medication or more medication. And trust me, they don't leave happy. And I've had some bad marks on Facebook about me because I've decreased their medication instead of increasing it. Poor scores on patient surveys, like I just mentioned. If the doctor's health grades drop, they're not going to have patients. So this scares some clinicians. And again, in the 1990s, pain was classified as the fifth vital sign, and a lot of push to alleviate pain was put on clinicians. And some drug manufacturers and representatives told doctors their products were not addictive. In the 1990s, pharmaceutical companies and medical societies claimed that the risk of addiction to prescription opioids were very low. And one pharmaceutical company in particular was convicted of persuading providers that their long-acting drug was not addictive and was safe in high doses. So all these factors contributed to the overprescription of opioids and some of the problems we're having right now. So we have to put the onus, based on the current literature, to the overprescription of opioids and, the clinician. But of course, we have to look at the behavior of those abusing or dependent on drugs also. And we have to look at the rise of pill mills and the illegal production of the synthetics such as fentanyl also. We need to explore the demand and not just the supply. So let's talk about abuse and dependence. Previously, opioid abuse and opioid dependence were regarded as separate diagnoses based on specific criteria. However, with the publication of the 5th edition of the Diagnostic and Statistical Manual of Mental Disorders in 2013, the two were combined under the diagnosis of opioid use disorder. Opioid dependence happens after you have used opioids regularly for a long period of time, and that time can vary. Some people can become dependent after 3 to 7 days, but dependence means that your body gets used to how much medicine you take. Dependence is not the same as abuse. Abuse means that a person uses opioids to get high or change their feeling instead of using opioids to control pain. Opioid use disorder has elements of both. These criteria are not considered to be met for those individuals that are taking opioids solely under appropriate medical supervision and taking them in the appropriate way. The diagnosis as defined in the DSM-5 is a problematic pattern of opioid use leading to clinically significant impairment or distress, and it's manifested by at least 2 of 11 defined criteria. It's a strong desire to use opioids, increased tolerance to opioids, difficulty fulfilling obligations, trouble reducing use, and withdrawal symptoms with discontinuation of use. The criteria are: number 1, opioids taken in larger amounts over a longer period of time than was intended. Number 2, there's a persistent desire or unsuccessful efforts to decrease the amount of use. Number 3, a great deal of time is spent trying to obtain the opioid or to recover from its effects. Number 4, there's strong cravings or desire or urge to use opioids. Number 5, recurrent opioid use results in failure to fulfill major role obligations in your work, school, or social life. Number 6, continued opioid use despite having persistent or recurrent social or interpersonal problems caused by the side effects from the opioids. Number 7, important social, occupational, or recreational activities are given up or stopped because of opioid use. Number 8, recurrent opioid use in situations that are physically hazardous. Number 9, continued use despite knowledge of having persistent or recurrent physical, psychological problems that's likely caused or made worse by the substance. Number 10, a tolerance, as shown by either a marked increase in the need for the amount of opioid to achieve the level of intoxication that is desired, or a markedly diminished effect with the continued use of the same amount of opiate. And number 11, withdrawal as manifested by either characteristic opioid withdrawal syndrome, which we'll talk about later, or opioids taken to relieve or avoid withdrawal symptoms. It's often described by the 4 C's: impaired control over drug use, compulsive drug use, continued use despite harm, and craving. There's severity of the classifications. So in the past 12 months, mild opioid use disorder is the presence of 2 to 3 of those symptoms. Moderate is the presence of 4 to 5 of those symptoms. And severe is presence of 6 or more of those symptoms. You can have some of those symptoms, but not have an abuse problem if they're not chronic for several months. Typically, chronic pain medication can create tolerance, can create dependence, and can have some withdrawals type symptoms in between doses, but the medication is being used properly, and under the strict guidance, there's not manipulation of the pills, so it's not considered opioid use disorder if taken as prescribed. So what are some of the signs? Although in diagnostic terms and per the DSM-5, there's no such thing as abuse anymore, it's still a useful term to indicate use that's longer in duration or greater in frequency than is considered therapeutic. The signs of abuse. Well, there's some signs you'll never see because the person experiences them, and that would be like a diminished sensation of pain or no pain at all, or the person's constipated. However, if you really look at somebody, there's some signs that you will notice, like constricted pupils, if they're very impaired or under severe intoxication, slow or shallow breathing, which is part of the respiratory depression effect and can be signs of drug overdose. But before the respiratory symptoms occur, some changes you might notice are impaired thinking, confusion, depressed affect, lethargy, lack of motivation, short temper, loss of appetite, change in weight, a change in a person's libido, maybe their appearance changes. They start to have problems at work, problems with people, maybe with school. Maybe they're ignoring their responsibilities, having financial problems, interpersonal relationship problems. A person abusing opiates may have some nausea or vomiting. You may notice the person has a flushed appearance to their skin, or they're itching. They, like I said, might be drowsy or sedated with slurred speech, but yet they're acting euphoric and happy, even inappropriately so. They might have poor judgment. So if they're abusing their medication and they can't get it, they might have signs of withdrawal. And perhaps that's the first sign you ever notice, is that the person's having some withdrawal symptoms. Maybe you're working in the hospital and they come into the hospital and can't get their medication, and now they're having some withdrawal symptoms, or they're coming to the hospital all the time just to get their opioid. Withdrawal symptoms, there's varying times when the withdrawal symptoms will kick in depending on what they've taken. But in general, they will start about 12 hours after the last dose, and they can last a couple weeks depending on medication duration, frequency, and their system, their physical biology. I was working in the pain clinic, and I had an afternoon patient, an 80-some-year-old woman brought in by her grandson and granddaughter. She was on extended release morphine, and I'd been seeing her for a couple months. She's usually always, we detox her, everything would be okay. And she came in and she was kind of cranky and agitated. She complained of tingling all over, and she was kicking her feet and really irritable. And she said she'd been taking her medicine every 12 hours out of her box. She said she'd been having restless, jumpy legs for at least 12 hours, and they were getting worse. She'd been nauseated. She felt feverish. Her pulse was 90, blood pressure 150/90. She didn't have a fever, even though she said she felt hot. So she wouldn't have chest pain or anything like that. I gave her 1 week's worth of pills. I did a urine tox screen, and I scheduled a follow-up. When the tox screen came back, there was no morphine, active morphine in her urine, and there was very little metabolite. So as it turned out, her grandson had been stealing her pills. With tox screen showing no morphine and only a little bit of metabolite, I knew she hadn't been taking them. So the person who has been going through withdrawal may not always look like you expect. So opioid withdrawal symptoms resemble a severe flu-like illness, might have runny nose, sneezing, yawning, watery eyes, belly cramps, leg cramps, restless leg, goosebumps, nausea, vomiting, diarrhea, dilated pupils. They'll be cranky and anxious. Like I said, this woman had tingling all over. And duration and onset of symptoms vary with medication used, whether it's long or short acting, and the person and what other medication they're taking, and drug interactions. Phase 1 withdrawal symptoms like irritation, sweats, muscle pain, flu-like symptoms, increased blood pressure and pulse for short-acting opiates will generally start in 6 to 10 hours after the last dose, but it depends on frequency and duration of use. Craving to take a drug is very high at this time, and people who are trying to quit, this is usually when the urge to take the drug is so high, they will relapse and start reusing, which continues the cycle of dependence. Early stage symptoms of opioid withdrawal typically last about 72 hours for short-acting drugs. For long-acting opioids like methadone or extended release products like extended release oxycodone or morphine, the symptoms may not start for 24 to 36 hours and can last as long as 2 to 3 weeks. Phase 2 symptoms involve depression, lethargy, maybe anorexia, and can last an additional 4 to 7 days, depend on the person and substance. For the long-acting opioids like fentanyl and methadone, extended release oxy, the onset is slower and the process takes longer. And then some people developed something called PAWS, which is post-acute withdrawal syndrome. And that can include lingering depression, insomnia, fatigue, lethargy. And this is in large part due to chemical imbalance in the brain from serotonin and dopamine upset. And PAWS syndrome is another reason a lot of people, even after the physical withdrawal is gone, a lot of people relapse because of that. Excuse me. Hopefully you never encounter someone who's overdosed on opiates, but as my example illustrated earlier, you probably will, especially considering the current epidemic. And if it's a prescription drug or an illegal drug, they need to be treated as an emergency. In case of the overdose, you may have noticed some of withdrawal symptoms, or you may not. You may see somebody extremely confused and drowsy. They may have nausea and vomiting, but the most dangerous is the lack of oxygen and breathing. So small constricted pinpoint pupils, falling asleep or loss of consciousness, slow, shallow breathing, choking or gurgling, limp body, pale blue or cold skin, blue nail beds, vomiting, seizure. They're all very dangerous signs of drug overdose. The World Health Organization describes what's called the opioid overdose triad: pinpoint pupils, unconsciousness, and respiratory depression. And that's a medical emergency. Without treatment, this person's going to die. So how do we treat an overdose? Effective treatment of an overdose requires recognition and the knowledge that is life-threatening. And you also have to know that the normal pharmacokinetic properties of the opioid are disrupted during an opioid overdose. Opioid absorption, onset of action, clearance, the biological half-life are often irrelevant during an overdose. There may be delayed gastric emptying, diminished gastrointestinal motility, and this may prolong the drug absorption. Duration of action can depend on the opioid use. Hydrocodone, oxycodone, and codeine can last several hours in the system, while fentanyl can last up to 72 hours. The property of the drug taken can affect the overdose. Methadone has a half-life of 60 hours and affects the heart rhythm, so that can also contribute to the dynamics of the overdose. The biology and health of the person taking them and other drug interactions can affect what's going on during the overdose. And if a person has organ system failure, they may not be able to clear the substance at all. One of the first concerns, of course, like we mentioned before, is respiratory depression. If the respiratory rate is less than 12 breaths per minute, you have to increase the ventilation, open the airway, and provide mechanical respiration and supplemental oxygen if available. And of course, call 911. And, look for a fentanyl patch and remove it, because, it's like spitting in the wind if you're trying to help somebody and there's a fentanyl patch on. And with a fentanyl patch, a lot of times they're flesh colored or clear, and they're not real big, so you really have to look around. Again, working in the pain clinic, I had a patient that I had inherited from another clinic. She was probably 85 pounds soaking wet and on a ridiculous amount of medication, pain medication, neurologics, anti-inflammatory, antidepressants, all the typical pain management medication. And she was also a smoker. So I was actively decreasing her medication every month. She came in for an 8 a.m. appointment and always wanting more medicine, of course. She was falling asleep while I was talking to her, reaching in her purse and falling asleep in her purse. Her color was awful. Her nail beds were yellow because she was a chronic smoker. But again, falling asleep, her respiratory rate was about 8. I called 911 and the EMTs came and of course gave her naloxone and sent her to the hospital because she was in overdose at 8 o'clock in the morning. So you never know. The administration of naloxone, also known as Narcan, is now standard treatment when the drug is available. It's an opioid antagonist and it competes for the receptor site with the opioid and replaces it on that site. It blocks the opioid from attaching to the receptor. It reverses the effects of the drug it's competing with. It can be administered intravenously, intramuscularly, or subcutaneously, and also intranasally, which is the easiest way. Often the administration of naloxone is enough to render only supportive care until full recovery is achieved. If you're given naloxone, you need to be calling 911 and send the person to the hospital. The nasal spray, like I said, is most convenient form and easiest for most people. It works very quickly. Naloxone acts within minutes, and its effects usually last up to 45 minutes. But remember, if a person was on long-acting medication or had been taking opioids for a long period of time, one dose may not be enough. It often depends how much drug was used, how they clear drugs, what other drugs they were on. So giving one dose of naloxone and thinking the person is cured is not the answer. They do need to go to the emergency room, no matter what they say. And it's like a miracle. If you ever give naloxone, a patient's obtunded and passed out, you give naloxone, they'll pop straight up. And if they're in chronic pain, they'll be in real pain because it totally reverses the opioid. So what are current interventions? Well, for the opioid crisis, we have two. One's an intervention directed towards the user, and the other's an intervention directed towards the supplier. We have to stop the demand and the supply. So user-directed interventions follow guidelines developed by organizations such as the Substance Abuse and Mental Health Services, individually designed programs for detoxification, medically supervised withdrawal and maintenance medications, psychosocial counseling, 12-step programs, treatment for any other psychological coexisting and mental health disorders. But first you have to recognize the problem. You need to discuss what you think is going on with the patient and maybe significant other, and then make a plan for an intervention. Are you going to cut off their medication? When I worked in the pain clinic, if we had a urine tox screen that came up with heroin or cocaine or something illicit, we just cut off their medication. There's medication tapering. You can do a slow taper, which is opioid reduction of 5 to 20% each month. You can do a fast taper, which would be a reduction of opioids by 10 to 20% each week. Or the fastest taper would be an opioid reduction of 10 to 20% daily. There's medication-assisted withdrawal using buprenorphine, which is a class 3 opioid. And buprenorphine was first approved for clinical withdrawal use in October of 2002, but it's been a pain medicine since 1985. There's buprenorphine and naloxone, which is known as Suboxone. It's a opioid and partial agonist antagonist. And both of these are drugs of abuse. So remember, if you're thinking of using these, some people just switch addictions. There's methadone, which is a class 2 opioid, and that's mainly used for heroin withdrawal, but some people will use it for some of the other opioid withdrawals. And again, it can be a drug of abuse. Clonidine, which is an old-time blood pressure pill, an alpha blocker, and also a sympatholytic drug. It blocks signals in the central nervous system and sympathetic nervous system to decrease some of the withdrawal symptoms such as shaking, nausea, irritability, insomnia, perspiration. And that you may feel is a little bit safer to use for people with substance abuse problems because it's not a controlled substance and it's not typically abused, but you do have to be careful if people have blood pressure problem or heart rhythm problems. Another thing, the World Health Organization recommends that we increase the availability of opioid treatment programs and the availability of naloxone. Naloxone, of course, isn't a treatment, but it can prevent deaths for people who are likely to have an opioid overdose. As far as the dependency programs, the government's trying. $9 billion in grants from HHS to states, tribes, and local communities to fight the opioid crisis was appropriated in fiscal year 2016 through 2019. In 2017 to 2019, there was a 142% increase in patients receiving medication-assisted treatment, which means 127 million Americans are now receiving Suboxone-type treatments. There's been a 106% increase in data-waived providers or buprenorphine providers, and there's 14,000 substance abuse facilities, more than 14,000 substance abuse facilities in the United States. As far as rescuing people from overdose with naloxone, it can be dispensed in pharmacies in some states without a prescription. The CDC recommends anyone prescribed opiates more than 50 mm's of morphine per day be prescribed naloxone. In order to reduce the risk of overdose death, clinicians should strongly consider prescribing or co-prescribing naloxone and providing education for its use to the following patients, and this is for CDC recommendations. If a patient's receiving opioids more than 50 morphine milligram equivalents per day or greater, if the patient has respiratory conditions such as chronic obstructive pulmonary disease or sleep apnea, if the patient has been co-prescribed benzodiazepams regardless of the opioid dose, and if the patient have non-opioid substance use disorders like excessive alcohol use or mental health disorder, regardless of the opioid dose. Also, patients at high risk for experiencing or responding to opioid overdose should have naloxone prescriptions available, and that includes people with heroin or illicit synthetic opioid misuse or prescription opioid misuse disorder, people who use other illicit drugs such as stimulants like meth or cocaine, which could be contaminated with an opioid, should have access to naloxone. People who've had treatment for opioid use disorder, including the medication-assisted treatments like methadone, buprenorphine, or naltrexone, and people with a history of opioid misuse that were recently released from incarceration or rehab facilities. So the CDC has put those guidelines into effect. Most health insurance plans, including Medicaid and Medicare, will cover at least one form of naloxone. And there are several programs at the state and local level that might even supply naloxone free or at low cost to those at risk or without insurance covering. All EMS services should be trained in the use of naloxone, and our county in Florida, Brevard County, has all the police cruisers carrying naloxone. So what are the supply-directed interventions? Well, many of the recommended supply-directed interventions refer to medical professionals. Their legal recourse is dealing with illegal suppliers and pill mills, but the family practitioners are often the source of the supply without even realizing it. And we talked about reasons for that. But the pharmaceutical companies are also on the chopping block. In March of 2019, Purdue Pharma reached a $270 million settlement in a lawsuit filed by Oklahoma, which claimed that its opioids contributed to the death of thousands of people and contributed to the opioid epidemic, and followed up with July just this year, 15 states reached an agreement with Purdue, the makers of OxyContin, that put $4.5 billion in settlement money towards opioid prevention and treatment programs. So that's because Purdue had been telling providers that OxyContin was safe and not addictive and not dangerous. So they're paying now. If you go to the computer, you Google pill mills, and I did this just to see what was going on now because I can't believe it's still going on, but you'll find headlines. November 16th, 2020, 46 were convicted in an $18 million pill mill scheme in Fort Worth. It included 2 doctors, a nurse practitioner, and 5 pharmacists. March of 2020, Philadelphia area doctors arrested in a massive pill mill bust. They illegally sold 2.1 million opioids. January of 2020, San Diego pill mill doctor pleads guilty to opioid distribution and signed prescriptions for dead and jailed patients. In September of 2018, 2 Tampa pill mill doctors were put in jail for 2 years. So it's happening all over the country, and it's still happening. The strategies have to be addressed that go towards the pill mills, but we also have to teach and implement the providers with standards of practice regarding how to take care of patients' pain. And it includes examining the patient, assessing the patients prior to prescribing opioids. We need to educate the providers regarding alternative pain management techniques, particularly regarding chronic pain. We need to educate the doctors regarding techniques to prevent patients from doctor shopping and getting several prescriptions from different doctors. So the CDC is helping in that regard as well. They've developed some pain management guidelines and recommendations. We have patient assessment and pre-screening tools such as the ORT, the SOAP-R, and the CAGE screening tool to see where patients are at risk for dependency. And to decrease doctor shopping, there's prescription drug monitoring database, or PDMP, which has been developed. And most states require physicians and pharmacies to enter controlled substances into a database. In Florida, it's called the eForce, and it was instituted in 2011, but became mandatory in September of 2019. And the PDMP mandates reporting of prescribed and dispensed controlled substance prescription. It collects the reported information in a database that tracks individual prescriptions, which provider prescribed it, what was prescribed, how many, and when. Initially, there were a lot of limitations. It showed only the state. The VA didn't document it, like Patrick Air Force Base didn't document on it, but recently it's gotten better. They're improving. There's some communication between states, because in Florida, we were finding people would go to Georgia and get prescriptions at a doctor there. You know, we have snowbirds here, so people go, you know, to their other houses and be doubling up on their prescriptions that way, but it's getting much better and crossing state lines. In 2017, the CDC issued their pain management guidelines, which included recommendations for opiate prescriptions involving determination, selection, and risk assessment. When treating acute pain, a 3-day prescription is recommended with a 7-day maximum, and they recommend using the lowest effective dose if you're using an opiate, and you have to designate acute pain on the prescription. When these guidelines first came out, they were not well received because they were considered mandates. They weren't well received by clinicians or public. the doctors felt like their hands were being tied and the patients felt like they were going to be tortured. They've been revised and reverted somewhat, and their guidelines. When treating chronic pain, which is pain that lasts longer than 3 months, it's recommended that you try alternative non-pharmacologic therapies first, like acupuncture, massage therapy, physical therapy. The problem with some of the alternative therapies, a lot of insurances won't pay for them, but it's still recommended that you try it. If you're going to use pharmacologic therapy, try non-opioid therapy first. Acetaminophen, ibuprofen, anti-inflammatories, neurologics, antidepressants. If you're going to use opiates, use the lowest effective dose for the shortest amount of time. And there's a strong recommendation for less than 90 morphine milliequivalents. You should pre-assess your patient using the SOAP-R or the ORT or CAGE screening tools to find their risk of abuse. Their patients are recommended to be randomly urine tested for the presence of their medication or for illicit medications at initiation of opiate and periodically as long as they're on the opiate. Naloxone prescription is recommended as we discussed earlier. Many doctors just don't even want to deal with it and they just refer to pain clinics for their chronic pain patients. It seems like these guidelines are helping because according to CDC statistics, in 2016, almost 215 million opioid prescriptions were written, or 66.5 out of 100 prescriptions. In 2019, 153 million prescriptions for opioids were written, or 46.7 out of 100 prescriptions. So it's improving, but there's still a long way to go. In Florida, House Bill 21 was implemented, which was a law aimed specifically at restricting opioid prescriptions for acute pain. That law imposed a 3-day limit on Schedule II opioids for acute pain. If it's not acute, you have to designate acute pain exception on the prescription. So let's try and wrap this up. The opioid use and overdose crisis are persistent and dynamic. Opioid overdoses were driven in the 1990s and 2000s by increased availability and misuse of prescription opioids. You know, there was reasons. It was prompted to treat pain as a vital sign and to alleviate pain practically, and doctors were pushed in that direction. But illegal opioid deaths, you know, we've gotten the control of prescription opioids a little bit, but illegal opioid deaths continue to climb. And it seems to be a recurrent trend over the decades that when prescription drug deaths decrease, illicit drug deaths increase. One of the 3 priority actions recommended by HHS is increasing the availability of access to naloxone for the treatment of overdose. This can help reduce the number of deaths, but it doesn't address the problem. While the number of prescriptions for naloxone doubled from 2017 to 2018, we still have opioid deaths. We have to address the supply and demand problem. Many efforts are made at supply, re-education, sanctions on prescribers and pharmaceutical companies, limitations on prescriptions, continued illicit drug trade war. But demand needs to be addressed. We need to continue community education and surveillance, open discussions with patient and family members, get to the root cause of substance abuse, improve availability and reimbursement for treatment of substance abuse. The government is trying by committing more money to treatment and recovery programs and to physician education. The CDC is updating guidelines and recommendations, and prescription drug monitoring databases are being updated. So efforts continue. Anyone who's seen their family physician lately might notice that he or she's not as likely to prescribe opioids as they used to. Some are referring, they're not writing controlled substances at all for pain, and they'll refer to a pain management clinic or just use non-opioid methods. If so, it's evidence that the interventions are working, but we still need to be aware that there's a problem, and this problem has existed for centuries. Until then, until we get total control, we as nurses must be aware and prepared for whatever opioid-related events come our way. Thank you very much.